Just check. Apologies for absence, Paul.
Yeah, thanks, Mike. We've got apologies from Adrian, Phil, and Lorraine.
Okay, and declarations, conflicts of interest. No. Okay, and before I move on to item 102, let me just quickly introduce our guests. Paul, could I go through you, please?
Yeah, Paul Johnson, Secretary.
Nat Shepherd, Patient Experience Lead.
Graham Holt, Lead for Podiatry for MBHT.
Natalie Ford, Deputy Associate Director of Nursing Community Care Group. Everyone.
You read non-exec.
Chief Medical Officer.
Hi, Chris Adcock, Chief Financial Officer.
Lawrence Scott, Chief Operating Officer.
And I'm Chief People Officer.
Morning, Tony Owen, non-exec.
Hello, Karen Deeney, non-exec.
Hi, Sarah Rees with Vet, non-exec.
Good morning, Amin Kamaluddin, non-exec.
Hello, my name is Aaron Cummins, Chief Executive.
Hi, Tom. Welcome. I'll make sure people on Teams get introduced. I'll call your names out if that's okay, and Paul can help me. So we start with you, Sakthi, please.
Morning all, I'm Sakthi Karunanithy, I'm advisor to the board.
Harry Cobb, can you hear us?
I can, sorry, I didn't know if you said Ali or Karen. I'm Carrie Cobb, Associate Non-Exec Director.
Ali?
Hi, I'm Alison Cole, I'm an Associate Non-Exec Director.
Okay, thank you. Jelly Barney?
Good morning, everyone. Jolly Barney, Associate NED.
And Nicola, please.
Good morning, Nick Barnes, Board Administrator.
Welcome. Suitable time in the agenda, I'll ask you to come in and brilliant. Okay, so forgive us while we go through the rest of the agenda. Okay, minutes of the Board of Directors meeting then on the 6th of September. So we want to move its correct records, subject to Sarah sending some corrections for the minutes. Yeah. You?
So they're correct.
All right. Okay, thanks, Steve. We accept their correct record. Thanks, Sarah. Action sheets, matters arising, through to the company secretary.
Yeah, nothing particular to highlight for the board. You'll see that a couple of actions have been completed and a couple of items scheduled are included in today's public agenda or private agenda later today. Thanks, Mike.
So colleagues, then we'll move to matters for consideration. Patient story, item 104, Chief Nursing Officer.
Thank you, Chair. Morning, everybody. This morning's patient story is based on what I call good patient experience, patient outcomes, and showcases the amount of work that teams are doing to improve patient safety and care that we provide. So I'll introduce Graham Holt, who's going to be talking to us about the story, and he's being supported obviously by Annette here and Natalie. So Graham will lead. Thank you.
Good morning all, thank you very much. So my name is Graham Holt. I am the lead for podiatry and I've been in post now for about 18 months. So as this is our first opportunity to present to the board, we'll just do a very quick summary of podiatry. So we currently have 29 members of staff, which equates to 24 whole-time equivalents. We've increased staff numbers within a reduced financial envelope by skill mixing over the last 18 months. Our main focus of the service is preservation of life and limb. We have a caseload of around 6,000 patients, and 300 of which have active ulceration at very high risk of amputation and early death. Next slide, please, Nick. Thanks. So we are professionally officially classed as vulnerable and at risk by NHS England. We're actively engaged in recruitment and retention projects with NHSE. We've been doing that for the last 2 years. We're supporting ministerial discussions on AHPs with a view to representing the trust and getting our profile increased. So we're meeting today with Susan Rastrick with a view to preparing for that meeting with Minister Caulfield. And we're developing the skills and resilience of the MBHT podiatry team so that all of our team work at the top of their banding, so the patients have the best experience wherever they go. So this case is about Mr. S. He's 49 years of age, so he's relatively young. A history of type 1 diabetes, stroke, depression, vascular dementia. Smoker with a long history of poor glycemic control. So that smoking and poor glycemic control have contributed to all those medical problems that he suffered over the years. He lives alone with his young cat, a history of depression and previously attempted suicide. he now has a strong friendship circle, and friends sometimes come to his appointments with him. So he's recently returned from Preston following a blown amputation of the other leg, not related to this case. And the team was supporting to make sure he's got the right rehab in place. As a service, we have the advantage of seeing patients on a regular basis, often for 30 or 40 minutes to an hour at a time. So we do develop relationships with our patients, and in this case, we do support this patient on many levels. So he lives in a high area of deprivation in Furness. He's currently unemployed, and that's because of his inability to hold down a job because of his diabetes and the problems that this has caused. The cost of living impacts on his life at present, so that impacts on him being able to eat effectively, manage his diet well, and that affects his diabetes, and also travel to appointments. But he's very pleasant and engages well with advice. He's a very, very nice young man. So he was admitted to same-day emergency care at ESTEC at Furness General in December of 2022 with suspected diabetes ketoacidosis. So we had wet gangrene of the right third toe, and there was evidence of the toe starting to come away. Now, I had put pictures in originally, but they were a little grim, so we've taken them out. So he was originally listed to be transferred to Preston for an amputation of the toe. So we worked with the vascular surgeon and carried out a leg of concern vascular assessment. So it's a detailed assessment for us to understand what is his level of arterial disease and how much intervention does he need right now. So we discussed bloods and the CT scan with the vascular consultant via telephone to undertake sharp debridement of the necrotic tissue. So they were happy for us to do it. So we removed all the necrotic tissue on that day while he was in ESTEC by the podiatrist. Thanks, Nick. So the patient was treated for infection and ketoacidosis over a couple of days, and then was discharged home after a minimum stay on oral antibiotics. So he didn't need transferring then to Preston. So we brought him back a week later, where we've reviewed the treatment plan, and the skin flap, which was left of the toe, was removed and sutured by a podiatrist following discussion with myself. And I was happy that the member of staff had that skill. They've done extra training that allowed us to do that. Then he was seeing vascular outpatients in clinic at that time with Mr. Kelvey. And after 2 weeks, the wound was almost healed and went on to completely heal another 2 weeks after that. So the intervention was positively impacted on the patient because it was an improved patient journey, a minimum hospital stay. He really didn't want to be in hospital over Christmas because of his, mental health and his past. He very much wanted to be around his family and friends. So the patient got home for Christmas. He had a very, very good time. He was really happy with the outcome. So he didn't need to go to theatre. We removed a speedy removal of the necrotic tissue and managed the infection really well to a granulating and healing wound. In terms of the healthcare system, so effective multidisciplinary working, advanced tissue management skills negated the need for costly surgical intervention. So this member of staff actually did it in their own time, but this is something we're looking at for the future. We're currently involved with the Vital and Vulnerable Services work with the ICU, and these are conversations that we're trying to have. We want to have pathways that really support these patients to have really quick, really effective interventions, particularly given that our vascular offer is not ideal across MVHT. So patients often have to go all the way to Preston, but actually we can do some of this work very quickly, very effective, very cost effective here in the Trust. Less pressure on inpatient services, costly ambulance transfer avoid, and reduced bed days. No need for this time and staff. So the vascular surgeon thought it was somewhere in the region of around £12,000, all that would have cost. Improving patient experience is one of the most efficient ways to reduce NHS costs. And they spend less time in hospital. From a perspective of someone who works in the community, when I spent time in Nightingale, I was absolutely shocked how fast patients deteriorate when they're in hospital, how fast they become institutionalized. So a win-win situation. And I'm happy to take questions. Thank you.
Okay. One of the things we do with patient stories, one, it allows board members to get a bit of an insight into your daily work and you know, the daily experience of patients, because that's what it's all about. It's all about patient care. The other is what would the board look at here? What would be the assurance questions that we would see really? So I'm going to open the floor up to questions, but if you don't get any questions, then don't assume that, you know, it just means that we are assured by the presentation.
Just well done, great, fantastic presentation, and brings to life, I guess, the bit you were making at the end, which is you focus on the patient safety, quality improvement, performance money, staff satisfaction, you know, work-life kind of improvement. It all follows. So as a board, you'll know we're talking about our continuous improvement journey, the soft ratings that we have, and our ambition to get to soft 2. That connection of quality, safety is what we're about. So that's a great lived example from one patient's kind of pathway. So thank you for bringing that to us, because it's important. I've got a question. It might be for Ali, this one actually, but this is a fantastic example. You started your presentation with a classification of the service as, you know, at risk, and then a really articulate view of how you as the lead and the team have worked through that on skills mix redesign into resource within reduced envelope, operating at the top of band. So as we talk about our workforce strategy and workforce plan, Ali, I'm assuming that kind of approach is something we're going to look to lift, share, replicate across other fragile services.
Yeah, I think podiatry is pretty unique, isn't it? And the numbers in training are so small that there is a as part of the long-term workforce plan, there's a recognition that podiatry is one of those services that absolutely needs to push apprenticeships as a methodology for kind of the future. And I know you're already kind of pioneering all the work around kind of the kind of development of the profession. So yeah, it's absolutely front and centre. But I think the podiatry profession is individually highlighted in the long-term workforce plan around apprenticeship expansion.
Can it be good to triangulate that with the work that Suzanne Hargreaves is doing on fragile services and the clinical strategy, Jane? Because if that's part of our approach on workforce plan to support or reduce fragility, I think it's a really neat segue. I think it's some of that work. It's really good. Thank you.
So we're currently part of that work. I was fortunate to lead the Trailblazer group for podiatry. So I led that nationally. And we've got 2 apprentices about to come into us for furnace, which is a great opportunity to invest in the area. So they're local people who can't afford to do a degree, but they have the ability to do it. So really pleased that that's going ahead.
Great stuff. Thank you. Thank you.
Very quick one from me. Is it still Salford that does the podiatry undergraduate programme, or do the universities do it now?
So there are a number of universities across the country, I think 12. We're linking with Plymouth to do the apprenticeships because they're the only one approved by NHSE to deliver virtually. Salford essentially compressed theirs, so people still need to travel. So it's a 3-day delivered, but it's still a 5-day course. So huge amounts of pressure on these students.
Thank you. Karen.
Thank you. Thanks, Graham. That was really helpful. I completely endorse everything Aaron said actually about the way in which you presented it and the lessons that have come through, and great to hear the way you've moved the service forward as well over the last 18 months. You mentioned that the person who performed the not an operation, the treatment, did it in their own time. So and obviously that partly reflects the fragility of the service, but I think just looking for some assurance to understand how we're mitigating against that for other patients, because obviously well-being of staff is also really important and we can't rely on that to keep patients safe.
Those the extra skills they brought have been invaluable. So I'm thinking, you know, where do we want to go as a service, and we're mapping it into what we want to look like in the future. I was very clear from a governance point of view that it was a reasonable and safe undertake that, but it's how do we then do that for other patients. And I have a very clear picture in my mind of what ACP roles will look like in podiatry that will allow us to have a medical ACP and a surgical ACP within the service cross-bay to be able to deliver that to all patients.
Thank you. And also noting you talking about investment into the podiatry apprenticeships, which I know for community services, that's one of the challenged areas as well in terms of feedback as well, isn't it? So that's really positive to hear. So thank you.
Thank you. I mean, having an NHP background myself, it's just brilliant to hear something so fabulously articulated in terms of that contribution. And just really building on and taking into account some of the things that you've already touched on, I'm wondering how scalable this is. How scalable is it for podiatry services to be done safely with the right experience? And also, what learning could there be for other professions that have got some of the same issues around fragility and vulnerability?
It's very scalable. So we have a number of staff who are, able to develop these skills. We just need the time and resources to support that. But also we need to develop good governance, links with the likes of vascular and orthopedics as well. So it's not about us doing this in isolation. It's about us working, having the whole system flow mentality. So we're doing elements of this, we're linking with these people all the time. So where it's not appropriate, we're able to signpost these in very, very quickly, certainly quicker than we are at the moment. Patients waiting 6 months for a vascular assessment. In terms of lessons for the services, I think it's a little bit tricky because podiatry does sit on its own a little bit in terms of where we sit. The perception of what we do is very different from the reality of what we deliver in the NHS on a day-to-day basis.
Thank you. Any questions further from colleagues?
All right. Great. Just with another hat that I wear, which is the lead CEO for the Provider Collaborative, I know that the other trusts in our area will be struggling for fragility with podiatry services. Are we sharing this model and this approach across the network locally in Lancashire, South Cumbria?
Yes, and across all the ICB work as well, the vulnerable services, all those services are involved. So one of the first meetings we're going to have is sharing of good practice.
Yeah.
So that we can take all the good bits and start to apply those across both.
Fantastic. Thank you.
Okay, colleagues. Yeah, anything else you want to say?
No, thank you very much for the time. It's been a pleasure to
really good. It wasn't. Some of us may follow this up and come and meet yours, come down to the clinical area. So if you hear from us, that it'll be a follow-up to this.
You're very welcome.
Thank you.
Chief Nurse, anything you want to do?
No, just to say thank you, just triangulate everything we're doing to improve the services. Thank you.
Thank you. Okay, colleagues, as we move forward with patient stories, we will get more into the why is it coming to the board? What is the rationale for us getting the presentation? But that's really interesting. Thank you. Hopefully we'll follow it up. Okay, we'll move on to item 105, Chair's report. You have it in front of you. I'm assuming colleagues have read it. Just a couple of things to highlight. We had our annual members meeting at Ulverston. It was dreadful weather. It was very wet and damp for those of you there, but we had a relatively good turnout considering parking was difficult and the weather was awful. And I'd just like to thank formally everybody that was involved, really, Paul and your team for organising it, make sure everything was there. And everybody who came with their stands. So at the same time as we had the AMM, we had the very first System Recovery and Transformation Group meeting where Aaron represented us. And that also, first meeting, but again, the first grip of collaborative work. And we'll hear more about that when we go through collaborative partnerships later on in the agenda. And also you'll see my report, a small short report from Karen regarding midwifery and maternity, and just raising to the board through my report an issue that hopefully will be resolved by October regarding a chair of one of the groups. But I'm happy to answer any questions.
It's worth adding, Mike, that the middle of last week we had the first ICB meeting of quality committee chairs. The second meeting, it was the first one that I could make. So we had I attended my first meeting of quality committee chairs. And I think that's a useful meeting, and I'll mention something about it later in the agenda.
Okay. No questions, colleagues. You're happy to accept the chair's report. Then item 106, Chief Exec report.
Thanks, Chair. So as normal, I will kind of break this into 3 updates around the national, kind of regional and local position, but very briefly. I will start off as I do in most of my briefs now at board with a thank you to colleagues for their efforts over the previous period, again recognising the continued disruption of industrial action. Again, we're on day 3 of the 3-day industrial action today. The reason I call that out and say thank you to colleagues is, I think I said this in the last month's report, our teams have become very adept and very skilled at managing and leading through these periods of disruption, but it doesn't come without some kind of impact, both for patients and colleagues. So during this period of industrial action, over 500 patients won't get the treatment or access to treatment that we're expecting this week. That has an impact on mental health and wellbeing, physical health and wellbeing, pain and worry, and we need to recognise that. And I also need to recognise that those colleagues that are supporting in this period, both through the days of the industrial action, but the preparatory work in notifying patients and then the rebooking, that is a really difficult and stressful environment to continue to operate in. So whilst we will give updates to board that feel rightly that we're managing the risk and actually we're managing it really effectively through these periods, there is an impact, and it's important that I recognise here at board, and we still recognise that. And I will end the message in this space, as I always do, that those colleagues nationally that are responsible for getting to a resolution in this area, we look forward to that progressing and getting to a position where the industrial action ceases. Just talking at the national level, there's a couple of areas I've mentioned industrial action. Financial position of the NHS is still the biggest driver of conversations, I think, for the national and regional performance frameworks. Chris will say a bit more about that under the IPR, and we'll spend a bit more time as a board in the coming weeks and months on our own forecast outturn, what we're doing in the leadership space in the system, and what confidence we can take as we exit this year into next year's planning. But the financial agenda is critical for us. Winter planning, again, Scott's going to mention some of this later this afternoon about our preparations for winter, but there's expectations around winter resilience, winter plans. There is a risk this year, particularly with the finances, that we're unlikely to get the levels of investment that we've seen in previous winters, and we need to consider carefully as a board the risks of that and what we do in terms of deploying precious resource around the winter period. Like I say, Scott will say a bit more about that this afternoon. And then the final piece from the national position, colleagues might be aware, I think we've circulated comms before, of the new NHS England approach to continuous improvement and that service improvement methodology and approach called Impact. There's going to be a national committee looking to standardise, spread good practice and get common methodologies of improvement through regions, ICBs and trusts. I think this is welcomed. We're lucky in that one of our local chairs, David Fillingham, who's the chair of LSCFT, is going to be the chair of that national committee led by Neely Hardy. And we're going to be conducting a self-assessment. So Tabitha, as the executive lead, is in the final stages of developing our own response and continuous improvement infrastructure and plan. I think that's going to come to either the next board or the board subsequent. Yeah, thank you. So we'll tie that in, but it's important we recognise that we're a bit ahead of the curve on the impact work, and a board proposal will come in the following month. I'm conscious, Hugh, in particular, this is an area of real focus for you, so I hope you'll be pleased with what we've developed over the past few months under Tabitha's leadership. More locally within the provider collaborative and the ICB, there is obviously a dovetail then with the national agendas, particularly on financial improvement and winter planning and resilience. But there's also some work within the provider collaborative that I'll update on. Colleagues will be aware that I chair and lead the central services collaboration work stream. Big piece of work that has just completed, which is the hosting of the Warn, Lancashire and South Cumbria model. We went through a process this past month, and East Lancashire Trust are going to be the host organisation for the hub as it gets developed. Again, colleagues will be aware Ali is our executive lead in that key work programme, and will bring some board reporting up through the coming months as that develops, and we understand the impact and the timing of some of the transfer work, and more importantly, the improvements and the outcomes that we're expecting as a result of it. Secondly, the other flagship programme of work is the clinical strategy for the provider collaborative. We've had quite a lot of work through the summer, just revisiting the strategic intent we've had here at board, which is around the principle of network of services, hub and spoke arrangements, kind of trying to strengthen the fragility of some services through working collaboratively. I'm meeting later with system leaders this week to put some flesh on the bones of a programme that turns that into a clinical service configuration plan. The what, by, when, where, what's the work that we're going to do over the next 1, 2 and 3 years. So by the time we get to the new hospitals programme, there's a real clarity in our system about the clinical service models in all acutes, not just the 2 new hospitals. So again, I'll bring the board a bit more when we get that into a better position, and Jane's our exec lead, obviously, in that space. For locally in the trust, again, finance and winter focus, obviously industrial action and electric recovery feature strongly. I won't sort of cover too much of that because it'll feature elsewhere on the agenda. I did want to say thank you for colleagues who set up and were participating in our Patient Safety Day, which happened on the 14th of September. Again, colleagues like Dame Henrietta Hughes, just to get those kinds of colleagues to come and talk to our teams. That's our third Patient Safety Day. We'll take some feedback from colleagues on the impact. We're going to use some of the learning to take into our own audit days and improvement work. We're likely to plan another one probably in the next 6 to 9 months. That was a fantastic opportunity again to hear from some of the best in the world actually around patient safety. We have got our national staff survey now out. Colleagues have got the links that they require to complete by the 24th of November. Last year we had just under 50% response rate. We're looking for a better response rate this year. I think it's important we continue with that as a signal of engagement. So board colleagues, if you've got access to the survey, please take the time to complete that in good time for us to get it in for the 24th of November. And the last point I want to make, Chair, I'd be remiss of me under my Chief Exec's report, not to mention that it's our Chief Medical Officer's birthday today. So it's Jane's birthday today, so happy birthday, Jane.
Just told me she's 29 for the first time.
That's my report, Chair.
Okay, any questions to the Chief Exec, Tony?
One comment and one question. I mean, first of all, just to say it, I think it is remarkable. I know I've said this previously that the trust continues to deliver the quality and quantity of clinical interventions in light of the industrial actions and even some aspects around COVID. I just want to put that on record because from personal experience and also from what I've seen and read, I think it is testament to not just the corporate team but all frontline staff and this trust in terms of how they're working through it. So thank you for that, and thank you for the really good report, Ryan. Aaron, my specific question, sorry about that, Ryan, well, just specifically in terms of the shared services model, just a couple of specific. Is there an indicative number that's already been agreed, and is that determined by business cases for shared services, or is it just at this point where work is still being undertaken around? Because when you look at the 30% reductions in ICB alone, which is in the other paper attached, then these are significant numbers. So I'm just trying to understand what that process. I know it's stuck coming back, but what's the process going on at the minute?
So it's a really good question. So the work started about 2 years ago around the central services improvement work, designed predominantly to align to the provider collaborative's ambitions about reducing duplication, common systems, operating as one entity as best we can for peripatetic workforce, etc. And we'd had a piece of work done at that time by Deloitte that said, actually, in replicating 5 times, we believe you have an opportunity of savings here if you reduce that duplication and streamline your services. And the transformation agenda around automation and kind of digitization. And at the time, I think that figure was broad around 40 to 50 million pounds as an opportunity. Now, obviously, that's 2.5 years ago. And over that period, a couple of things have happened. Each individual trust has been taking some of that transformation improvement work into its own services. So there has been contributions in our own CIPs for some of that restructure, change and improvement in the corporate functions. And what we've used the case for change for, the Deloitte report, is to work with our professional leadership groups to say, well, how do we set ourselves up as a system to best take advantage of that opportunity? We call it a target operating model, with a number of suggestions from outsourcing to one of the big global firms that might take it on for all of us, through to staying as we are and taking individual transformations through units. And the target operating model that was agreed was one LSC. It's a single leadership function. We bring in a lot of the service management and the infrastructure for things like systems and processes centrally, but not for everything. There's been a piece of work done. We call it D1 to D4 without going into the methodology too much. D1 will be very transactional, like payroll and ledger. D4 might be some of the very specialist occupational health or organisational development piece that you want to retain locally. And we're just at the process now of signing off that model. So we've agreed the centralisation as the target operating model. We've agreed the host. The professional groups are now in training with looking at the delivery path for what comes into that central model, what gets retained locally. And as we work through the transformation service by service, there will be individual business cases that are really clearly articulating for estates and facilities, for example. As we transfer and put the central function together, what's the 3-year improvement path? What's the case for change individually? What is the measure of improvement, quality, performance and money that we take forward? And that's the construct. That's how we'll now start to build the programme of change. So we have a case for change and a model agreed on the back of it. We've got a process of hosting and centralising functions, transactional initially. And then we've got a transformation agenda, which will build case by case to start to explain how we transform services under that model to release the efficiencies that are remaining out of the back of the paper.
That's really helpful. Just, and it's probably been, you've probably been informed previously, but that's quite complex in terms of the process and that kind of sequencing of decision making and gateways, and has implications in terms of our own internal financial targets, because obviously it's about actually hold them and wait, or if it takes too long, then it's a cost pressure on the bottom line. But put that to one side. Just remind me, what's the decision governance gateway process for this? Because in some senses it's a collective approach, but then the decisions and the consequences of that may have an impact, good, positive, or something different for the as a trust. I can't quite remember what that process was.
It'll predate lots of colleagues here. So it's under the mandate of the Joint Committee for the Provider Collaborative, who are holding the reins on making the decisions around the central services work. That said, as it moves into this next space, what I've asked Angela, who's the lead company secretary in the Provider Collaborative, to do is to make sure that we're dovetailing executive leadership within each host trust. So Ali is our executive lead. That's now been completed. All trusts have an executive lead for the programme. And to make sure that we've got an internal executive functional group, which Ali chairs here, on risk mitigation, planning, engagement, communications with the corporate teams. And then we'll dovetail into the board updates, particularly around that alignment to deliver against targets, staff engagement, following due process for things like TUPE. The board will have oversight locally through Ali's leadership on what we're doing in that space. So that's how the two are dovetailing. When the cumulative decisions come around partnership, investment, transformation, that will be under the auspices of the Joint Committee. But we still have the responsibility and accountability of the board to maintain safe services, deliver effectively. So that will dovetail alongside.
Thanks, Aaron. It's just a question in connection with the Patient Safety Day, which is just brilliant to bring people with that kind of national and international profile here. And what I'm thinking is when I join those kinds of things, as I quite often do, I'm often concerned about the reach and the breadth of staff who are engaging in it, particularly frontline staff. And I'm wondering, how much do we know or do we track about how many people engage with that fantastic opportunity? And how much do we know about what the return on investment is in that kind of event in terms of how does it impact transformation or safety improvement, or can we track that in any way?
The short answer is probably not, because it's too ethereal. It's like how do you do a cause and effect from a talk at a meeting into a quality and safety metric? But what we generally have is 50 to 100 colleagues live. So if you're in and out, you'll see the 50 to 100 number. When we record it and then we put it out to care groups and others to use in audit days and other programmes, and it's on the intranet for colleagues to kind of make contact with. Now, in terms of impact, we do surveys on the back of it and take a view on what we want to do for the next programme. And there's always an ask in the meeting for colleagues to take them back through their own quality improvement and governance structures to consider how best to deploy within their own improvement work. But I'd have to come back and talk to the governance and the patient safety team to see if there's anything else specifically do in that space. But I can see Jane wants to come and chat.
So thanks, Karen. Mine was sort of not really to answer that, but to sort of complement that really, that I had a conversation last week with one of the patient safety reps about I'm conscious that for doctors you have to cancel a day's activity to do something like that, and you can't often dip in and out that easily. So I spoke to them about how can we try and either do it so well advanced that there's a real expectation that we've got good representation and taking the hit on activity to a certain extent, or how do we try and deliver differently? And if there are particular things from that that we want to deliver to teams, how we actively do that rather than just it's on a website, go and look, which you often just don't, either I can't find it in the moment or you don't have the time to do it. So we are looking at some of that.
Just to add to that, Karen, just before you come into that, if you don't mind, just for information, the NHSE has approved a draft patient representative strategy. Its next stage will be, it'll go to the ICB, and then it'll go to the trust boards, and there'll be, within the strategy, there'll be opportunities for us to do further work around patient representative work. Some of our patient reps groups, James, have been involved in that draft work, and I think you're right.
I have to say, I think the patient safety days have been fabulous, and it's just it's almost a shame, isn't it, that you can't have complete amnesty for everybody to be there.
Absolutely, it's that kind of,
Yes.
so when I mean return on the investment, I mean, what's the impact on outcomes then? And I know it's difficult to absolutely pin it down, but surely we have to get better at.
Thank you, Chair. I'm just taking the action on behalf of the CEO to say the patient safety and governance team. I'll talk to the team. The day was amazing and see how we can use some of what came from the day in terms of our patient safety and quality improvement. So I'm taking it as an action, and if there's something we can assure board on in terms of what happened that day and how we are spreading it out, we'll bring it to the pack.
Any further questions to the Chief Exec? No. Thank you. Do we accept the Chief Exec's report? Yeah. Okay. We'll move on to the Head Governor's report. Lorraine can't be here this morning. She sent her apologies. I think we take the paper as read, and I'll just check with the company secretary if you wish to add anything on the Head Governor's report.
I think just one item that would be worth noting by the board. Lorraine, as the head governor, sponsored the sort of first of what will be a number of governor development sessions taking place through this year. It was kind of facilitated by Tony, as senior independent director, with support from my team. It was a very good success, first session with the governors, a time for reflection to think about how they want to operate in the future. And the next session will be taking place later this month. Thanks, Greg.
I'll just check. Any questions for the governor? No, we're happy to accept the lead governor's report. Thank you. We'll move on then to quality and safety, and we've got 108 maternity safety update. Just before we bring in the chief nursing officer, to just say that any exceptions or escalations will be reported to us by the chair of the quality committee. So I recognise that it sometimes says it in our papers that the update reports are in the reference pack when they're actually in this pack, but anything from the quality committee that you wish to escalate up into the board's attention?
Nothing that isn't already in the summary of the issues in the assurance paper. And regarding the 3 papers that I mentioned there that actually sit in the main body, we considered those in July at the quality committee, and I rechecked the minutes and my notes from that meeting, and there was nothing that we highlighted of concern that needed to be brought to the board regarding those 3 papers.
I'll ask the chief nurse to introduce the item and just contextualise what other groups have looked at these papers as well, please.
Thank you, Chair. These reports are just here to give board assurance and update you in terms of the maternity work that's happening, the improvements that are happening, and all the safety work happening within maternity and neonatal services. And as you has already said, they've been to quality committee, and some of the papers we've discussed as the maternity safety champions, where we go through things in detail and actions. So I will introduce the director of midwifery to just pick on what needs to be alerted to. Thank you.
Thank you. Heather, are you here? I don't think she's come into the meeting yet. Check the time, we are a bit early. Heather, could I ask your permission if we move on to item 109 while we wait for Heather to join us?
Yes, Chair, that's fine, thank you.
Okay, if we move on then to Chief Nursing Officer, still yourself, Tasta, on the NHS England communications regarding the trial and conviction of Lucy Letby.
Thank you, Chair. We all have heard about Lucy Letby on the news, or one way or the other, the trial of Lucy Letby. And following that, there was a letter that came from NHS England to all trusts in terms of what we need to do to ensure that our services are safe and that we allow our staff to speak up. So this paper that's here is actually in response to the letter that came from NHS England and to assure board of the actions that we've taken as an organization. So it's here, it shows the actions. It's a lot and I'm not going to go through it, but just to assure everybody to say, this case is very sad. We need to find a way to support our staff, to support families and patients who access our services in terms of we are still a safe service. So if you have any questions, please ask me. And I can only say we are also discussing it as a region to make sure that the Lucy Letby, nobody can guarantee that we haven't got a Lucy Letby, but what we can guarantee is to have a plan, governance processes that actually talk to us in terms of reporting, assuring around our incidences, and most of all, encourage our staff to speak when performance is compromised or when patients are compromised. So if any questions are there, the report is there, Chair. Thank you.
Just to add to your paper, Chief Nursing Officer, if you cross-reference that to the ICB Chief Exec's update as well, you'll see in there that the ICB will also be looking out to roll out some of the recommendations. We'll have additional medical examiners looking at injuries and deaths, for instance, and there will be cases around cold testings of cases, whether they're injured or not. Those sort of things will be rolled out in these papers, and that will come to an action plan afterwards as well. Any questions to the Chief Nursing Officer? I'll go Karen, then Sarah.
Yeah, it was it's really endorsement and support the question, particularly for this system-wide approach. Thinking particularly of neonatal care, we will have neonates and families and parents whose care might originate here, but isn't necessarily delivered here because they're very poorly babies, but actually they're still very much part of our community. So being assured as a system about anything in response to the Letby case is just really important for us to stay sighted on.
Thank you. Note that, Karen. Sarah.
Thank you. Actually, I think I've answered my own question, which was in terms of thank you, which is actually about where we'll see this in future, and I see it's come through Quality Assurance Committee, so we'll see it there. And I also wanted to commend it in terms of going beyond what the letter asked for and actually considering more widely what we needed to look at. So I think that I really endorse that approach as well. So
thank you.
Yeah, so we considered this in detail at the Quality Committee, and I think the point that Sarah's raised was noted that the approach taken, because it wasn't the original letter, if you read the original letter, is quite vague in the approach that you should take as an organisation to addressing this. And I think Richard and his team have decided to take this in the form that they say, that treating it as if it was an alert. And the fact that 8 of the actions don't actually come out of the letter, they come out of the wider noise, if you like, and that's been in the media and concerns that have been raised. So I think we felt that was a very strong approach, and we supported that approach. And it's not an approach that's being taken universally, he told us, across the patch. So that led us into the conversation about, well, what happens? How the neonatal tertiary units, we don't want sort of all the organisations that feed into them asking them for assurance. That's not appropriate. So Richard, I can confirm, has written to the ICB's chief nurse, and at the meeting that I was at last week, she confirmed she'd received that, and that was supported by the other Quality Committee chairs, that we actually needed probably a regional approach rather than just an ICB approach, because the the neonatal units that we're talking about are regional units. So I just wanted to sort of confirm that we support the approach in this paper, and confirm that a lot of the actions that put here, we can be reassured, I think, that those steps have been taken. We wait for the assurance to come about our regional units.
The recommendations, colleagues, is to approve, we have an approved to note, an approved, an offer to note, to note, to note. So I'm not going to read them all out. You all got them in front of you, but let's just deal with the approvals first. Be happy to approve the recommendations there. Okay, and comfortable with noting, with the noting elements. Yeah, and then offer any additional actions which should be considered helpful within the broad parameters that could reduce the possibility of criminal activity. Who wouldn't? Okay, so we need that. Okay. All recommendations approved and noted then, colleagues. Thank you. Heather, welcome. I see you've joined us. Welcome. Just to let you know, we'd already discussed the context of item 108. We recognise we've had an update from the Chair of Quality. This went through there in July, and the Chief Nursing Officer has also contextualised the various scrutiny groups that he's gone through within the trust. So I'll ask Tabitha to introduce you, and then we'll move on. Tabitha.
Thank you, Chair. Morning, Heather. If you could just give a brief update to the board in terms of the areas that they need to note. Thank you.
Thank you, Tabitha. Thank you, Chair. So I'll take the paper as read, just to highlight the key points. Obviously, we'd identified at last board we were challenged around our training compliance. I'm pleased to report that all trajectories, except for anaesthetics, is due to be over the 90% by the 1st of December, and we have sought care group support to hopefully increase the anaesthetic attendance at prompt by December. Over the 90%. So that's a real improvement for us. Maternity staffing is safe. It's mitigated by bank and agency. Our establishment currently will aim to have minimal vacancies by December, and that is due to our programme of work around internationally educated midwives and newly qualified students. The maternity dashboard, I'm pleased to report, will become the maternity and neonatal dashboard from next month, with the inclusion of metrics around neonatal data. Our board level safety champion visits have started to include special care and neonatal services now, and an opportunity to engage with neonatal staff around their experiences, but also an opportunity to engage with parents and families whose babies are in special care environments. The service has developed a CQC action plan in response to our overall rating of requires improvement from the CQC. The board paper clearly articulates we were aware of all our risks at the time of inspection, and I'm pleased to report that our trajectories for completing that action plan, other than the 3-year strategy, hopefully will be achieved by December. We have a new MVP chair that's been appointed via Healthwatch, commences in post this month. This is really important because some of our co-production work has been rather slow due to the changing of the chair. Cultural improvement, we received the cultural diagnostics report yesterday, but only the highlights. So the quadrumvirate team and wider have yet to fully consider the whole report, but we will provide some feedback to board next month on that. And the score survey has just closed, so we're yet to receive the final compliance ratings for the survey. Update on CNST. In this paper, because CNST is a moving target, in this paper we're detailed or on trajectory for 7 out of 10, and actually at the moment we're on target for 9 out of 10. Aiming for 10 out of 10, but at the moment we're 9 out of 10. We received a LMS assurance visit for the CNST evidence for year 5, and they were pleased with our progress. The maternity support programme has got a visit planned for October, and that's where we will discuss our exit and the requirements to exit out of the programme. Entonox suspension is just awaiting ratification of a SOP to enable the staff to use Entonox more safely in the home environment. Thank you, Chair.
Thanks, Heather. Questions from colleagues? Very concise, Hugh.
So Heather, I've got a question that follows up from obviously the news that we're now sitting at looking at 9 out of 10 for CNST rather than 7, because when we considered this, obviously equality asset, things move fast, don't we? We were all sort of looking at, well, not glum, but just sort of thinking, oh, right, we're perhaps not going to progress. Can I just confirm that the one that we're still not achieving is the transitional care staffing issues? Is that because that seemed to be the longer term issue, that we actually had to get quite a lot of things in place for that to be secure and going forward?
I'm pleased to report, Hugh, that it's not. The standard we're yet to achieve compliance is actually the training standard of hitting 90% by December. The original ask for CNST around transitional care was around having the staffing model in place. Now, we did discuss at board last month about it was incredibly tight turnaround for NHS England. Obviously, they provided some funding for us to pump prime the staffing model, but there wasn't enough time to put it in. So once we got the business case approved, we've gone back to NHS Resolution and asked if they will treat a signed off business case and reporting to board monthly as compliance, and they have confirmed in writing they will accept that as compliant for this year.
That's a very sensible decision, isn't it, by then? So the issue outstanding is the training compliance. So there's a significant chance that we could actually hit that if the anaesthetists put their shoulder to the wheel, so to speak, which would be incredibly encouraging.
Jane, do you want to come in?
Yeah, I know Heather had been in contact with the surgical triumvirate, and I've spoken to them yesterday. So they were all actively looking at how they could manage that. It requires, I think, 5 more people to have had the training by a certain date. I think there's only something like 8 outstanding in total, isn't there? So it's not, it's a huge number, but they're looking at how they can facilitate that, bearing in mind it's within the time we would normally accept people cancelling activities to do so.
Excellent.
Thank you. Any other questions from colleagues? Heather, thank you, and Chief Nurse, thank you for that report, and good luck on the MSSP visit coming next week, isn't it? It's the 11th
Yes.
of October. Good luck with it. We'll take each paper in turn, is that all right?
Yeah, thank you, Chair. So the next paper is the Attain paper. This is noting for CNST purposes, it would have gone through Quality Committee in July, just to assure the board that we have below national target of unavoidable admissions, which is 6%. Obviously, we've discussed transitional care. The report goes into the differences in terms of outcomes for families in regards to baby separation in there. But obviously, we've got the business case now approved, so we'll hopefully move that forward at pace, and we will provide board with monitoring around that action plan. I'm happy to take any questions.
Sarah?
Thanks, Heather. I've just got a question around the differential we've got around the number of term admissions at RLI, because although our overall figure is well within the sort of national target of 6%, at RLI we were edging towards that, and so really asking for some assurance in terms of, I think that related to the last quarter of 22-23, so whether that's a continuing trend, and whether the transitional care model is expected to bring that down.
Yeah, thank you, great question. So for assurance, the unexpected admission rate is monitored by the neonatal network as well, and we have some of the lowest rates in the region, so we are noted on that quite frequently. We also look at the cases in terms of the themes, so as a quarter, we review and see if there's anything that we could identify, which obviously is detailed in the report. Because we're a small service, the numbers can fluctuate quite considerably. So it's just something we track, but there's no concern other than obviously we've got what themes that we'll work on, which we've got action plans for. But what we see is our numbers do go up and down, but as a rolling overall, they generally stay under the 6%.
Okay, thank you. And then do we expect the transitional care model to also support that aim as well?
Yeah, particularly at RLI, yeah.
Thank you.
Okay, no further questions on Attain, just so that we go through the formal minutes. You gave an update previously, so I just want to confirm for the minutes, we note the update that was given.
Yeah.
And then under the Attain report, we note the report, there are no recommendations in it.
Yeah.
Yeah, okay, then we'll move on then to 2 maternity and neonatal safety champions biannual report, please, Heather.
Thank you, Chair. So this is the maternity safety champions report. I will take the report as read. It just articulates for CNST purposes, Safety Action 9, around what activities the maternity and neonatal safety champions have undertaken. I do note that there will be a section on that also within the NED report. So I'm happy to take any questions.
Just a brief addition to say that just to assure the board that we've now got a full complement of maternity safety champions across all of the roles, including neonatal. And at the last meeting, we had a full house. A really strong group.
We'll put that in the minutes, Karen, so an update, because we're asked to note the January to June 23 report, but we'll take that as a verbal update to where we are now, if that's okay. Okay, colleagues, we're asked to note this report.
Yeah.
Thanks, Heather. Then the Embrace Maternity Newborn Infant Clinical Outcome Review.
Thank you. So this is a report into the 9th confidential inquiry of maternal deaths. That looks at data from 2018 to 2020. Obviously, the confidential inquiries always use rather old data. So it talks about the significant non-significant statistically increase in the maternal death rate during COVID. You will see that there is a robust action plan to address all the actions identified within the Embrace report, the 16 recommendations. 18 recommendations, sorry, 16 we are fully compliant with. There's 2 partially compliant recommendations that are reliant on other providers' involvement as well. And it's basically just for the board to receive this report and assurance of the plan in place to achieve full compliance, which from our perspective, it is compliant up to the actions we can be without the influence of other providers who we're working with to achieve compliance with.
Thanks, Heather. Any questions for Heather on this report? It's not fairly succinct, I think. Asked to note it. And no recommendations. Heather, thank you very much.
Thank you.
Thanks, Heather. Well done.
Thanks, Heather.
Yeah, good luck, like I say, and hopefully we'll get an update on good outcome for next month. Anything you want to end the report on, Chief Nurse?
No, just to say thanks to Heather and team.
Thank you. Colleagues, we move on then to paper 1110, Deputy Chief Executive. We're on the IPR now.
Thank you, Chair. So just to make a connection to the action log before I begin. So meeting was held with non-exec colleagues and the team behind the IPR performance and BI team on Monday this week. My team have fed back very positively about that. I haven't had any conversations with non-exec colleagues, and I need to catch up on what follows on from that. So, but just to confirm that it was happened and it was very well received by my team. As the board will hopefully recognise, the exec summary report, which now accompanies the IPR, has been further developed and enhanced and provides quite a structured summary of the information presented within the report, the IPR, the integrated performance report in totality. So therefore, I propose, Chair, we just go straight into the exec updates from that position. I'd hand over to Chief Nurse. Quality and safety.
Thank you, Chris. Thank you, Chair. So in terms of quality and safety on the IPR, I just want to assure board from page 133, where we are seeing a sustained reduction in terms of our reported incidents in the moderate and above harms. And over July, we've only seen 12 incidents that have been reported through our strategic incident system, which is STICE. In terms of our falls, which formulate part of our fundamentals of care, which is on page 134, there's been a total of 1, 2, 3 slips, trips and falls, and one of those resulted in moderate harm. And the patient slipped post-hip replacement, which resulted in dislocation. So there's not been any evidence of lapses in care, and that patient had capacity, which means they were not on deprivation of liberties or anything like that. So 15 patients who fell more than once in our care were patients who have got capacity, who have got a risk of fall. So we're looking at how can we reduce those 15 and ensure that even if they have capacity, what can we do to reduce those kind of continued falls in one person, for example. So all moderate and above harm incidents are being reviewed through care groups and presented at the weekly harm-free meeting, which we hold. And we have the executive review meetings every week as well to look at our incidents, look at learning and how we can support clinical areas in those areas. Pressure ulcers as well is part of our fundamentals of care. You can see from the summary that we've tried to highlight that we've had 44 hospital-acquired Category 2 pressure ulcers. And we've highlighted each one. I don't know whether the board will want detail like that, but this is just to ensure that 7 incidents showed lapses in care, lack of evidence and interventions provided. 7 incidents, no lapses in care. So we're trying to explain the pressure ulcers in terms of what were the significance, what did we do right and what didn't we do right, so we can continuously improve the care.
Just pause then, if you don't mind, because that seems like a proposal to the board. So I'll just check. Colleagues happy to receive those detailed reports? I think they are useful.
So I think what we have here is a summary in terms of 27 incidents with lapses and 17 where there weren't any obvious lapses on the trust's behalf. At the quality committee, we go into dig into those in more detail. So I think the high level report that we have here, which I think gives us confidence that we're not just saying we've had these pressure ulcers, but actually they're being looked at in more detail, which I think is really positive. And we actually commended the team, particularly the deputy chief who did. So did a lot of work on
the details to quality.
Yeah.
Then any exceptions
highlights
to the board. Yeah.
Thank you very much. What I'll do is I will pass over to the medical director when I've finished VT and mortality. So I'll go through other patient safety like infection prevention, which is on page 136. C. diff has remained below the national threshold for the 3rd consecutive month, which is really good for us. We have got no concerns to highlight for board in terms of IPC. Even though it's not on this report, I just have to say, whilst we are on IPC, COVID rates are kind of going up. So I'm just making a note, verbal note for board. Going to
cause COVID rates are going up amongst patients.
Amongst patients and staff.
And staff. That's leading to more admissions and longer stays.
Longer stays and leading to staff sicknesses.
Odds away. Thank you.
Thank you. I'll move over to patient relations, which is page 138, just to guide everybody. We have got only 8 complaints beyond 6 months. So I'm actually quite proud to say that. We are going to bring a detailed report, as was discussed in last board, in the November board, to give like a trajectory of where we were from 2021 to where we are now. There's a lot of happening within our complaints. We've got revised metrics, which will be introduced in October to Quality and Safety Committee to improve oversight and performance within complaints. The highest risk and problem we've had with our complaints is the team, because we've got quite high level of sickness and we are in the process of also recruiting, just so board are aware. But I'll bring an assurance report in November.
And if the, with the board's permission, after it's gone through board scrutiny in the rebel department, could we do a summary report for the Council of Governors as well?
They have requested one.
Yeah, thank you.
The mixed sex accommodation is there. I'm not going into detail.
Just check because Sakti's put his hand up.
Oh, is it? Sorry, I wasn't looking.
Well, thank you, Chair. I think it's probably worth coming in at this stage. It's great. It's a great narrative that Tabitha you've just described. I was just looking at the dashboard and comparing it with other dashboards subsequently in the report. I was just wondering what on the assurance column, it's all compared to the other domains. I was just wondering what would, given the positive narrative that we're learning, what would make that assurance column pass across all these metrics? Because everything seems to be going in the right direction. And I was just wondering from the board's point of view, what would make the assurance column go blue or pass?
I would have to work with the BI team, Sakti, and see how we can showcase that and give that assurance. So I'll take it up and talk to the team. Yeah.
Well, yeah, and also we'll take questions at the end if that's all right, so we can carry on with your report. Just to respond, Sakti, and we'll also have a board discussion on a SOC 2 entry strategy, and part of that will of course be improving these scores and maintaining them. So that would be part of the action plan anyway. Thank you for that.
So the mixed sex accommodation, I won't go into detail about that. The detail is in the report if anybody's got any questions. But the one to sort of give a bit of a narrative is our friends and family, because last board there was a question to say, how come we've got low figures in our inpatients and how can we improve the response figures? So looking at our response rate, 15% response rate, we are in the range of 13% response. So we've created some posters and some Q codes to see if our patients can actually start telling us what they like about our services whilst they're still in hospital. Because what we've been doing is waiting for them to be discharged and then send a text. And once they're home, other things take over. So responding to us has been, so we're trying to target and have patient experience teams go into clinical areas and talk to patients and families whilst they're still with us to see if we can improve that target. Thank you. And I'll hand over to the Chief Medical Officer for VTE and mortality. Thank you.
So VTE remains stubbornly not at the target. Our new VT lead is working really closely with the surgical care group in particular, whose triumvirate lead has got particularly good handle on systems, but there's something around, I think, how we have articulated who doesn't need a VT assessment, not quite translating into that on our systems. And it's quite a stubborn thing to get to. So they're doing a lot of work. I know it's reported to the Quality Committee with deep dives, I think quarterly or 2 monthly.
I think the next one's next month.
Yeah. Medicine, interest in the medicine inpatients has gone up to above the 95%. And they weren't entirely certain what they've done differently. But the one area that they were struggling with was cardiology, where it was the sort of day case inpatient procedures rather than patients who were in for a long time with an illness. So that may be some of that sorting, that coding out, but we're working on all of that. It isn't just a case of people not bothering. I think we're conscious that it's not just a lack of people doing things. So we will try and get to the bottom of that, but our new VT lead is working closely with surgery in the first instance. So we're not in a position as ever to give assurance around that, but we are doing our best to try and get to the bottom of it. Mortality, a different picture. We're in a good place with mortality. As always, our overall mortality is very low. we have two areas, and again, it comes to Equality Committee regularly, two areas: acute cerebrovascular disease, which has been a red highlight for almost about 12 months. There was a little peak in July or August of last year, and we think that towards the end of the year, this peak will drop. However, it has continued and has raised up a little bit again. And so the Amita and the mortality team are doing a deeper triangulation of complaints, incidents, coroner's referrals, inquests, etc. on all of those deaths to check that there are no themes that we've not come up with previously or that we're not aware of. But all of the cases are reviewed by the opposite site that the patient was on, and there have been no particular themes identified and no issues around the care. So we'll just continue with that. And then the other one is a little bit of an anomaly. It's a superficial injury contusion. It's a small number, it's 17 deaths. More than half of those were in the community. But what we found is that as I think was our first probable assumption, only a quarter of the deaths in hospital and only a third of those in community were actually coded correctly. And so there's a big piece of work on around clinical recording, working diagnosis. It's how you phrase things. You can no longer put, you have to put working diagnosis or as a particular terminology, or treat as. You can't just now put differential diagnosis. That doesn't allow for coding in the same way. So there's a piece of work going on around how we code and making sure that we're doing that as well as possible. But it looks like a coding issue rather than a care issue. So that's really mortality highlights. So happy to take questions at the end.
Thanks, Jane. Chair, the next section is the people section, so Chief People Officer.
Yeah, so on the vacancy side of things, we have made some really significant appointments, particularly in the medical workforce. That means that that recruitment activity is being tracked through in the financial forecast associated with temp spend reduction. So the nursing vacancies, again, they remain really low compared with others, and the international recruitment pipeline has been adjusted because of the position that we're in now, but it will be kept under review to make sure that we're able to kind of make sure that there are safe staffing arrangements in place. I have to call out Dan West actually with some of the fantastic professional leadership that he's provided on the work to reduce agency in the nursing workforce, and that's been supported by the reduction in vacancies, but actually the scrutiny and the professional leadership that Dan has shown, I think, does need to be called out here. And just so you are aware, the time to hire measure, I think if you remember last month, I said there were two measures in the report. Unfortunately, the wrong measure has been taken out. So we'll get that corrected for next month. So you are going to then be looking at the measure that is associated with what was in the long-term workforce plan. From an appraisal perspective, we've seen a further 4% improvement in the month, and the new appraisal system, which has the intention of making things easier but also improving the quality of the appraisal discussions, that has now finally launched following lots of stakeholder engagement. I will just say that because of the timing of this and the fact that the National Staff Survey is out now, I wouldn't expect to see the measure around the quality of the appraisal discussion being reflected, the improvement being seen in this appraisal year. I would imagine that we'll look into the next National Staff Survey. And then just finally on sickness, we can see that it's increasing. Tabitha mentioned the increase primarily associated with a spike in COVID infection, but we are seeing the highest ever recorded demand for occupational health services, and particularly around psychological support for colleagues. So the team are managing that within the KPIs and are still performing really well in terms of access times, but they are under increased demand and pressure, particularly because we're now in the kind of flu and COVID vaccination season as well.
Probably ask colleagues to speak up. I've just asked Paul to get some cool air in because the temperature of the rooms got quite warm. So this will go on for about 10 minutes, then the temperature will come down to the thermostat, and that will switch off. So just for colleagues on Teams, we probably need to just speak up for these next couple of items. Chris?
Thanks, Chair. So finance is the next section. So the summary headlines and key messages in respect to the month 4 financial position are set out at page 128 of the pack. Just continue to report performance in line with the bottom line financial plan, albeit has identified some fairly material risks to the achievement of the year-end deficit control total. These include impact of industrial action, increasing financial impact of industrial action. Obviously, we've got our eye on the potential risks and costs associated with winter as we get clear about what that might look like. Scale of the improvement requirement, you know, the board's aware of this. It's a significant issue during the second half of the year, and things like full cost of pay awards and direct or indirect costs of inflation. So inflation could hit us in terms of what we buy, but it could also affect provision around us and so forth. So there are all sorts of issues to deal with. It's important to note that the Trust has submitted its application for cash support in line with that required to support the deficit plan, and that's as approved by the board last month. We are approaching the point of the year also at which we, as part of an overall system-wide process, will be required to formalise the year-end forecast and set out our specific expectations and our responses to the identified financial challenges, and provide a board-approved plan for any recovery actions required. We will brief the board on the process to be followed and our plans associated with that later today. At slide 151, the board will also note the latest, the position of the financial improvement programme. We now have schemes within our WAVE system, which is the system we use to record our financial improvement initiatives and then monitor and track progress against them. The values in that system now exceed the annual target, and the progression, which is 30 million, and the progression of schemes recorded under levels 0 to 3 in particular would therefore be fundamental to our response to the risks identified in delivering our year-end position, along with reinforcement of our financial control environment, assurance and support for delivery of care group financial plans and recovery actions, some specific exec level and organisational responses to material identified financial risks within this, and a clear objective focus on the Trust year-end exit rate. So we'd expect to be briefing the board on those matters in due course. And that's the end of the finance section, Chair, and I'll hand over to Chief Operating Officer.
Thanks, Chris. So for urgent care, obviously the emergency care, and you see the 7th point of common cost variation for 4 hours. In this month, 76.5% above target, but in common cost variation. It's worth noting that Furness General Hospitals had its 6th consecutive month of over 76% performance, which is testament to the very good work they've done there. Ambulance handover within 30 minutes, you'll see in special cause improvement, which is positive, and between 74 and 80%. The Q3 stretch for that is 80%, and that's incentivised as part of the winter arrangements. Not meeting criteria to reside remains stubbornly at 16 to 18%, and more to follow this afternoon in the winter plan discussions around not meeting criteria to reside. For stroke, the validated data in the pack saw the 2nd consecutive month of a SNAP A at Furness and a SNAP B at RLI. The unvalidated data for Q2 as of Sunday at midnight was a continuation of that A at Furness and B at RLI, which remained at the 3rd consecutive month of those scores, which is hugely positive. Diagnostics, you see our 7th consecutive point of special cause improvement. We remain in the top 10 in England for our diagnostic performance, and should be very proud of that. For cancer, the national reporting metrics changed on Monday, and so you'll see the current iteration of these SPC charts today, and in the November-December board, you'll then see a new iteration of those in January reporting October's performance. But for the three important targets, and the key milestones will still remain as operational important milestones that will be the reporting charts that change. But for faster diagnostic standard, that's now 18 consecutive months exceeding that target in the top quartile. 2-week waits, better than target in month, still in common cause variation, and 62 days, again above target but in common cause variation. But we've done some quite considerable work in this reporting period on 2-week cancer upgrades. So where a referrer refers a patient in good faith as urgent or routine, and the triaging secondary care clinician believes that patient needs upgraded. There's some work to do in that space, so we've done significant task and finished piece of work in the 2-week upgrade space. And then finally, in access to elective care, we previously alerted the board to the 78-week potential risks in restorative dentistry. Those remain a risk, although we have secured some temporary locum support, which will hopefully mitigate the majority of that risk. It does remain a risk. You'll see reported in the pack a single 78-week breach, which was a human error, and some local learning around that. And finally, we remain on trajectory for 65 weeks. The industrial action risks to 65 weeks sit exclusively in trauma and orthopedics and paediatric surgery. Continue the work we're doing on that. Nothing else in that section. Thanks, Chris, Chair.
That's everything. Thank you, Chair.
Thank you. So we'll open the floor up for questions. Questions from the floor?
Maybe a couple if I can, Chair. So the last time we had the quality and safety IPR, we talked about falls, pressure ulcers, and the line of inquiry we opened up was the triangulation with staffing issues and the not meeting criteria to resign numbers. So I can still see that we've got particular hotspots within that report. Have we completed that triangulation, or is that something the quality committee is having a look at?
It is something we are actually doing to try and get it. We receive a safer staffing report every month through quality committee. And at the moment, there's no evidence of safer staffing impacting on the falls. But the criteria to resign, we're looking at that because there is a bit of correlation. So if board wants assurance, I can bring it next month. But yes, it's going to go through to quality committee.
Chair, can I make that connection with the winter? I'm really concerned about our level of not meeting criteria to reside at nearly 20%. It's not okay. It's significantly different to other providers in our patch, and it provides a risk against our financial outturn, winter plans, and the safety risk. So we'll talk a bit about it this afternoon. I think we need to put something a bit more structured and formal as a board into the system about looking for an action that will give us some confidence and assurance that can reduce, particularly over the winter period. So I just wanted to make that point. We would seek board support for that, Chair.
Absolutely. Yeah.
I've got a second question if I can, Chair. It's around BTE. So we've got quite a stubborn kind of plateau now, haven't we, about some improvements and not quite getting to where we need to get to. Really good to hear the leads kind of get into the nuance of particular service areas. It'd be helpful, it might not be for today, but to get a trajectory of when we expect that to be hit based on the actions and the issues that we're facing now. So if we can start to look at that as a trajectory for improvement, to be helpful.
Should we ask for that through the quality committee?
Yeah, so we're getting another report. It's either November or December, and we'll ask them specifically to give us that.
What I heard was a bi-monthly update, but I didn't hear the trajectory for improvement.
Yeah, that's why. So we'll ask for that.
Thank you, Chair.
Jane, can you?
Yeah.
Thank you. Aaron?
Yeah, thank you. It's just a question for Jane about mortality. I can see the highlights that it comes through the SPC and the mortality. I'm just thinking particularly with neonates in mind, but also with other, I'm thinking particularly with neonates in mind and other less frequently occurring groups. Would we see an emerging pattern where the number of deaths is a small one?
So it would not necessarily immediately pick up through SHME and HSMR because they're a longer term thing, but they are ones that have process around them. There's a whole process if we have a child death, so they're not invisible to us, and so they would highlight if we suddenly had 2 or 3 deaths in a month that we weren't expecting. It probably wouldn't be through this, but it would be highlighted. And our ME team are just doing work to have access to Badgernet so that they can scrutinise any of those deaths also. We're trying to join it all together.
Yeah, thanks, Chair. I want to commend the covering that, because not letter, but the covering report, particularly the elements around looking at those that are consistently passing, hit and miss, and consistently failing, because that was one of the issues that we raised at the meeting on Monday. Particularly this concept that you can be consistently passing when your waiting list is numbers are clearly not passing, and so this is sort of a slight anomaly, isn't it, the way we've dealt with and the need to recalculate baselines and such like. So I think it was picked up then, and it's great to see it actually highlighted here as an issue. And there are a number of areas that we probably need to recalculate, because as you go through, it's becoming very clear, but then you see a run of blues and you think, right, okay, there's a run of blues and we're going in the wrong direction on those blues and they're all below the target. So it's perhaps how we become sophisticated about that, I think, is important going forward. So I've got a couple of financial questions. I've got one very minor activity question about cancer, but I don't know what cancer PTL stands for. I was racking my brain to know what PTL stood for. It's in the title of the chart, cancer PTL, and I went to the glossary and I went to the metrics. I couldn't find it anywhere. So you can perhaps just quickly tell us what it means and then get it.
Scott or Jane? He's
Scott, I think that is.
Scott, just say what PTL is.
Patients tracking list.
Ah, right. Okay. So if it could just be in the title of the slide, because there's plenty of space. There's loads of space on the title to put patient tracking list. Now the financial ones. This might be my inability to understand things properly, but so the forecast outturn, as you highlight, why is deteriorated by 8 million in month because of rebasing and various other things, and you list what they are. But then it says that in month we're actually 28k better than plan. So I understand in one sense why when we said 27, but the sums are actually 28, but that's a minor thing, just to show I get my calculator out. But it's I was wondering where we represent on our charts that 8 million, or do we not, or do we just accept we've rebased? Because do you understand what I'm asking? Am I being very confused about that?
And I've generally tried to be careful about describing a forecast at the moment associated with this, because I don't think we've finished. For me, a forecast is something that has exhausted all of the things that we need to be doing, and there is a defined process that we go through. So I call this a forecast risk assessment. That's the first thing. Now, the deterioration that was referred to is that within our overall plan, we expected certain things to happen. Now, in particular, we anticipated, because planning guidance required this, that a programme of work would get our not meet criteria to reside numbers down to 5%. And in the context of that, and by the way, that's not inconsistent with other places. That's an indicator of the scale of the issue for us. In the context of that, we would be able to deliver savings on our bed capacity, infrastructure, and other things. So there is at this point in time, we don't yet have a trajectory that gets us to 5%. So we've made an adjustment in our likely savings delivery for that. On top of that, there are other cost pressures around the utility contracts in particular that we have adjusted for, because we've now got more up-to-date contractual information. You'll remember that we agreed through the Finance Committee to go to a more flexible variable contract, whilst we, because of the current uncertainty, we have a better sense of that. So there are other things in there, costs of the pay awards and things that have become aware. So these are identified financial risks. You've heard one thing that we're going to do to escalate the not meet criteria to reside piece. How will I quantify that? Well, we will do that in conjunction with the action. So these are absolutely appropriate to escalate these as financial risk in our year-end position. But I still think we've got more to do to see how far we can go to mitigate them.
That's helpful. So that's really helpful. So if those risks come to pass, they will be represented on the income and expenditure chart as blips. Well, so if for example, we don't, you know, our costs for fuel, those risks that you've highlighted actually come to pass, obviously our expenditure will go up and they will then appear in the monthly sort of.
You would see us likely go off plan.
Yeah.
And we would articulate why we have gone off plan.
Yeah, I understand that. And then I have a question connected to that, because we now say that we have provided in month 3, the Agenda for Change pay award was paid fully in month 3 and funded. But there are still risks associated with pay. Is that what you're saying, that you've now put into that risk?
So now that we have all the information that we need around certain aspects of the pay award, what happens is that an organisation gets an uplift to fund the pay award based on its total contract income. So then there can be nuances about your workforce construct that means that there might be cost pressures associated with that. And this is in particular, so we've seen pressures around the medical pay award actually. So again, I still think that we just need to fully understand what's driving that, and make sure that we've made the right representations around that, and we've just exhausted our opportunity to manage the pressure.
And in previous years, we've seen a blip around in March for the pay run rate, and quite a large one last year, which was obviously then mirrored across in the total picture. Does that, what you just said, mean that we're unlikely to see such a March blip this year?
The blip is because of when the actual costs get transacted. So remember, you quite often get a backdated pay element because the award is applied in retrospect. So,
right, so even though we've funded them, that we might see that
the actual expenditure will be relatively lumpy.
Right. Thank you for that. Sarah?
Thank you. Just got a couple of questions on operational performance. So one was on cancer 62-day screening. We've seen a sudden downward blip on that. And I know we're not supposed to worry too much about smuddling, but it's quite a significant drop. So it was just to ask if that's something we expect to resolve quite soon. Does that relate to breast screening, which is covered somewhere else in the narrative? And is that then likely to show in our overall 62-day performance if we've seen that drop off pre-screening? That's my first question.
So 3 things, yes. So it's a small denominator. You're right, it is common cause variation, and lastly it is in breast. So we've seen in the last 2 weeks our breast screening recalls go back to the 3 weeks threshold that they were up at 6 weeks prior to that. So we've seen improvements in this. So I expect that to come back up, certainly above the median.
Okay. Thank you. And then my other one related to the 12-hour ambulance handovers, and some of the narrative we've got against 4-hour, 12-hour is around the frailty intervention team service. I think I've raised this previously, but I don't think we quite got to the number of it. So in the actions, it talks about that we're currently providing a service 50 to 60 hours per week versus a 70-hour per week requirement. So really my question, because that's a narrative we've had for a while. So my question is, how do we have a trajectory to get us to the 70-hour per week requirement, and when would we expect that to resolve?
I guess so no, we don't, because we've got an important calibration of our resources. So the first thing, it's not the one thing's unfortunate, it's not a requirement. Nobody requires us to do it, it's a recommendation. So that line is just unfortunate. We'll change that. And it's best practice, absolutely, to have 70 hours of a fit service. At Furness, which has got the least amount of hours deployed for fit, as I said in the report, was 6 weeks, of 76% performance. We expect that to sustain. So in our asset, poor environment, investing in that, it feels like it would take us above average and is that something we'd be willing to do at this point? So I get, at the time these plans were made, and Investec fits and so on, was over a year ago, and the previous unscheduled care plan, would I be seeking additional resource to invest in fit at this point with some of the metrics we have? Probably not.
Yeah.
This winter, we will want to do something bespoke around older people, because we know about the trolley rates and corridor care, that those are people most at risk. And so we'll want to do some work on that cohort. Will it be investing in a bespoke fit team, as we maybe envisaged 12 to 18 months ago, I think about.
Okay, so it's a little bit about the narrative there at the moment. So, okay, that's helpful. Thank you.
Colleagues, any other questions? Just one for me, for you, please, Jane. It's reassuring to know that the mortality coding was a coding issue, that there's training in place now. When will we get assurance that that coding is working and that people are actually using it?
So, well, we'll see whether or not we continue to increase months. It obviously take a few months for this sort of to even out, but there will be through the mortality triangulation, I guess they will see if there are further cases, because all of these cases will be examined individually for a little while. So any other cases that crop up with that coding, the leaders team will be reviewing those to see if that is the case.
And that'll go through.
Comes through mortality committee, mortality triangulation to quality.
My other questions to Chris. Chris, obviously you're making assumptions for these last few months of this financial year, but the criteria to reside, that's going to impact significantly on the budget in terms of how many people get through the door and how many people get out the door. And it's going to obviously impact on patients. We're assuming criteria to reside is around 16% at the moment. 5%, let's be honest, is that realistic within the next 4 months? We've got the winter coming. How will you feed that into the budget planning?
So I'll be feeding it into the forecast, Chair. I've already, our last quarterly forecast review, we identified there was a risk against this assumption that assumed we would be able to reduce our actual expenditure by about £4 million. We already downgraded that last time. We'll be working with our operational teams to revalidate where we think that's headed. But at the moment, I would say that holds the same expectations.
It's just support what the chief exec says about escalating this to the ICB, because you know we're pretty good on our SIG, we're pretty good on the run rate, but this criteria to reside could just scupper this end of year planning that we've got. We need to make them aware of that, really. Okay, happy to accept the reports for the July, Tony?
No, just a clarification on that. Really important discussion at the end there in terms of the criteria to reside. So is that conversation, because it is a system-wide discussion as discussed previously, is that taking place at the System Recovery Board?
So yes, it features at the Recovery and Transformation Board under the Urgent Care Improvement Programme. But I think that's a longer term kind of system calibration, social care resilience, etc. We're now looking for a short, sharp intervention locally, unequivocally, and quite apologetically in the Bay, because we are such a differential rate. So that'll take part in the form of a conversation with me and the chief executive of the system, and see if we can get a chief executive of the local authorities conversation going, see if we get action taken. We are in an unfortunate position in that this is one of those areas of system working that's still at a level of immaturity. Again, the contracts, the structures, the ways of working aren't quite set in the way that we would want. So it is more difficult than I'd like to try and get actions and delivery in this particular space. But I think given the risk highlighted in the areas of concern for winter, we need to try and get best endeavours in the system to support the Bay, given them it's a differential impact.
Absolutely.
Really happy to accept the update reports to July. Yeah, thank you. We move on then to 110.2, minutes of the 3A reports from the Assurance Committee. Who's going to speak on the People Committee? Adrian sent his apologies. Look to the Neds, who was there?
I was there. I think it's a really comprehensive report and would take that as read. I think the only comment that I would add in addition is it was my first meeting. It was really packed, it's really thorough, it's really comprehensive. But I would add that there was an overall theme emerging of how do we get better at really making clear the connection with so what question. So this is about our people and largely our workforce, and how do we triangulate this? How do we really track the impact it has for patients and communities? So it's an important theme, one that will be in development, but I kind of think it underpins all of agency.
Nothing to escalate to the board. Finance and Performance Committee.
So yeah, happy to keep talking and take the Finance and Performance Committee, which again we've taken as read, just particularly to highlight the alert. It really builds on from the discussion so far, and the committee, although this is obvious, I think the committee have just made very explicit now that whilst things are on plan, this is still on plan against a deficit. We absolutely need to keep that firmly in our sights. And the committee recognised that now there's a great deal of very regular work with the care groups, both through the performance accountability framework, but also through the connections with the finance team directly. And we're very conscious that actually it is the decisions and thinking and actions that take place largely at care group level that are the big influence that's going to make the big difference. So the committee resolved last time to take even more focus on that, so that the committee can really effectively support and challenge Chris and Scott and teams to make sure that we're really not leaving any stone unturned. So it's just great to focus on that. Recognising there's a huge amount of housekeeping systems, processes really thoroughly in place now, but it's actually those three categories that's critical. So a really strong focus on that. Just to highlight that particularly it appears on the agenda that the committee reconsidered and approved the response to the communication from NHS England about protecting and capacity. We were happy that that would be appropriately signed off, but it was just with the caveat that the quality impact assessment for the patient engagement portal had been completed prior to that, just because that was an influential piece of work that would impact on the protection and expansion of elective capacity. Other than those 2 points, everything's in.
Just for board's minutes, so we get it correctly in the records, the response to NHS England communications protection, expanding the effective capacity, was a formal report that went through finance to be returned to the centre by the 30th of September. But I think we should acknowledge that the board endorses and supports the action taken by that subcommittee. Colleagues happy with that? Yeah, thank you. Thanks, Karen. Questions from FNP? No. Quality committee minutes.
Thanks, Chair. Apologies for the summary not being here. That's due to a IT issue of something being stuck in a draft rather than being sent. So I'll take full responsibility for that. Just the key things that we were going to that we discussed, we're going to highlight. The alert was really, which we've discussed, was around anaesthetic training within maternity and the impact that would have on CNST. But we've heard some very good news today to may well see that solved by the 1st of December. In the advise area, it was to just highlight that we were getting much more detailed information around pressure ulcers and whether there had been lapses of care or not. And there were actually perhaps more lapses of care than we perhaps expected, or it wasn't just lapses. It's not just lapses of care, it's also when the documentation is incomplete. So it doesn't mean there's been necessarily a lapse, it just hasn't been documented. So I just think we need to be careful about when we talk about lapses of care, if it sometimes means that the documentation isn't there. Mortality, we've had the update around what the coding issue around contusion and around Let B, we were going to inform the trust that we were seeking assurance around the situation and how we get assurance from the tertiary unit. So those were the things we were going to highlight and we've raised.
Questions for quality? Colleagues happy to accept the 3A reports from the various subcommittees? Thank you. The next item we've got is a morning break, colleagues. We're slightly ahead of the agenda. It's 10:45. Should we break for 10:55, 10 minutes?
If you wish.
Is that your cake? My apologies to those on Teams, colleague. Apparently we have cake in the room.
We'll sit and eat it.
10 minutes break.
Happy birthday, Jane.
Thank you.